As we follow this case further, unfortunately, the end or the second half of the story isn't as good as the first. While we might have expected a patient who had an early molecular and early cytogenetic response to dasatinib not to have resistance or relapse develop, that is in fact what happened. Past the 3-year mark, despite an early and deep molecular remission, patients started to experience symptoms which might make us concerned that there's a change in her status or her disease is returning, fatigue, weight loss, etc. And a prompt investigation, which is the first thing to do when there's any suspicion, showed us that she had a fairly robust relapse. She had a molecular relapse of significance, had return of CML detected by cytogenetics from the bone marrow. Fortunately, her blood counts hadn't risen, and that wouldn't be the way to check for relapse. Obviously, a deeper dive, a more careful investigation would have been warranted. And the most important thing, I think, that mutation testing was done and that a T315I mutation was identified. Now, in a patient with chronic phase CML with resistance after dasatinib, I think that's an important line of questioning. Could that mutation be present? And that really is an important fact because it definitely drives decision-making and treatment choice. There really are limited options for these patients, but there are very good options, and particularly ponatinib. There are other things one could treat a patient like this with, such as amacitaxine or historical therapies we used prior to the tyrosine kinase inhibitors. But I think the response and the safety, even with some of the concerns we have over cardiovascular risk and other issues, is clearly pointing us towards ponatinib in this case, and that's what was chosen. I think that was appropriate. Currently, the starting dose of ponatinib is 45 milligrams per day, and I think that's the right answer right now, although many of us are interested in settling the question about could a lower dose be a more proper starting dose for all patients. I think we have important trials that are running that should answer those questions. But according to the label and according to general recommendations right now, 45 milligrams would be a good initial choice for this patient with this robust relapse. The side effects of ponatinib are well known at this point, and in a patient with active CML, I think thrombocytopenia, which is what happened in her case, isn't surprising. As is appropriate, a dose reduction can be considered and taken, and a dose of 30 milligrams may be quite effective still in many patients, and may be ultimately a dose that we feel like that is better to use for most cases or many patients. And as we can see over time, this patient did quite well. She had improvement in her molecular parameters after 3 months, showing more than a log reduction. By 6 months, she's started to have deeper response, and by the 6 to 12 month window, she's already reestablished a deeper molecular remission, and we actually can't detect a T315I mutation any longer. Her disease burden is very low, and that mutation may not be evident at this point. So this is now a success again, and I think this is a difficult situation, resistance after initial success, but as we can see, there are solutions to these problems. There can be data-driven based on mutation testing and knowing the details of the case, and we can still salvage such patients quite well.